In cardiology, angina is a very specific term, and it has a fairly clear definition. But in medical practice, often that term is used in a very broad sense before it can be actually confirmed or clarified. Angina, strictly speaking, is pain coming from the heart, and it's caused by underlying coronary artery disease. Put simply, you develop blockages in the arteries of your heart. And when that occurs, when those blockages, or near blockages, reach a certain degree of severity, then whenever you exert yourself, your heart has to work harder in order to provide the blood supply to your muscles so that you can exercise. So the heart has to work quicker and more forcefully. Therefore, it needs more blood of its own because it needs blood to supply fuel in order for that pump to work harder, which is what the heart is. Now, if you've got a blockage or a near blockage, then you'll limit how much blood you can send to the heart. And when you get this imbalance between what the heart needs for its own blood supply to work harder and what it can actually get through, if you like, blockages in its blood supply, then that imbalance results in chest pain occurring on exertion, and that's called angina. And angina classically is described as a central chest tightness or constriction. Some people, the classical description is as if someone is sitting on your chest, the so-called elephant on your chest type of description. And the other classical feature is that it occurs consistently when you exert yourself or if you get very stressed or upset. And it will go away usually, hopefully, if you stop exerting yourself or if you administer what's known as a GTN spray. So some patients, while they're undergoing evaluation for chest pain, the GP or the cardiologist will give them a spray to put under their tongue if they get chest pain on exertion. And if you get chest pain and it occurs on exertion classically, and then it stops either when you stop exercising or if you give the spray, it promptly goes away. This is suggestive that that chest pain is coming from the heart due to angina and due to essentially, most commonly, a blood supply problem to the heart. So coronary artery disease is very common in Western societies. It can have a number of factors which are associated or contribute or cause the development of coronary artery disease. And we divide them up into modifiable risk factors and non-modifiable risk factors. So the modifiable risk factors are things like if you're smoking, that is a very strong risk factor, especially if you've been smoking for many years. It leads to the development of blockages in your blood vessels of your heart. If you've got high cholesterol levels over many years, then you promote the development of coronary artery disease. If your lifestyle is not particularly healthy, so you don't take regular exercise, you're significantly overweight, you drink alcohol excessively, all these are factors which can contribute to the development of blockages in your heart vessels, known as coronary artery disease. But they are modifiable. You can stop smoking, you can get yourself fitter, you can lose weight, you can look at your diet to reduce your blood cholesterol or even be put on specific treatment. The other type of risk factor is non-modifiable. So that means you can't do anything about it. That usually refers to genetic predisposition. So sometimes we know that coronary artery disease runs in families such that people are affected at a relatively younger age. To some extent, coronary artery disease develops as you get much older into your 60s, 70s and 80s. So to some extent, it's an age-related condition, but sometimes people have bad genes running through their family, which means that they have a higher predisposition to developing coronary artery disease at an earlier date. So the investigation of possible cardiac-related causes of chest pain is very well established. And currently, there are specialist clinics called rapid access chest pain clinics, which general practitioners can refer patients to if they suspect that their chest pain could be of a cardiac cause. Or they can refer them formally to a cardiologist in an outpatient's department setting. The investigation of chest pain usually starts with a number of basic investigations. It obviously, first of all, starts with taking a proper history from the patient, examining the patient, but then investigations would include blood tests. It would also include a 12-lead ECG, an ultrasound scan of the heart known as an echocardiogram. The cardiologist having taken a history, performed an examination, will already formulate a probability that your symptoms and your background history, how likely it is that you've got coronary artery disease. And that initial impression is important because that then determines which further diagnostic pathway that patient will go down. So, for example, if after initial evaluation of taking a history examination, an ECG, and maybe some relevant blood tests, if the cardiologist feels that your chest pain is quite unlikely to be due to coronary artery disease, in other words, your symptoms are unlikely to be due to angina, then he or she will probably want to consider an investigation which puts the patient at lower risk. In other words, a less invasive test, which will hopefully reassure the patient and the doctor that the chest pains are not due to significant coronary artery disease. Such tests include nowadays commonly a CT coronary angiogram, or some patients get put forward to a stress test, which is now advocated or recommended tests are now include a stress echocardiogram or a myocardial nuclear perfusion scan. Now, if having taken a history, examined the patient, the doctor feels that this chest pain is likely to be due to underlying coronary artery disease, then the doctor will make that as the kind of running diagnosis that you probably do have coronary artery disease. Then the doctor will start you on appropriate treatment, and commonly the patient may be referred for the gold standard diagnostic test, which is known as a full diagnostic coronary angiogram. Now, that test is more invasive because it involves putting catheters into the arteries up to the heart under X-ray guidance. It's done as a day case procedure, but it is more invasive. And the patient needs to be properly consented about the benefits and the small risks regarding this procedure. But it is the gold standard test, which gives absolute 100% clarity as to whether the patient has underlying coronary artery disease and how severe that coronary artery disease is. So, after that initial evaluation and appropriate investigation, if the gold standard test it shows that the patient does have coronary artery disease, then it depends upon the severity and the pattern of that disease. So one option would be that after doing a coronary angiogram, a discrete severe narrowing or near blockage is identified in one blood vessel or maybe two. And if that narrowing or near blockage of the coronary artery is anatomically ideal, then often patients will be advised for what's known as coronary stenting. That is a procedure which, from the patient's perspective, the experience is the same as having an angiogram. They will be lying on a table with an X-ray machine around them, and the cardiologist would already have done the diagnostic angiogram by putting catheters up, commonly through the wrist artery up to the heart under X-ray guidance. So that would have been done already. And then the procedure is just slightly longer, whereby the cardiologist will proceed to open that blockage with a stent. And a stent, if you like, is a microscopic metal framework which can be inflated within the artery or within the coronary artery, such that the blockage is opened up, so restoring normal blood flow. And obviously the attractions of this procedure are obvious. It doesn't involve open heart surgery. The patient goes home, can commonly go home the same day after an uncomplicated procedure. They will be put on blood thinning aspirin type drugs for a certain period of time, but it is a kind of less invasive way of restoring blood supply, and its attractions are obvious. However, in some patients, when you do the initial diagnostic study, they may have a pattern of disease where they have narrowings or near blockages in many arteries of the heart. We call that multi-vessel coronary artery disease. And if you have that, and especially if you have diabetes as well, or if the pumping action of the heart is not 100%, then the data tells us that these patients are better treated by undergoing what's known as coronary artery bypass surgery. Now, that is open heart surgery. It has to be done in a cardiac surgical center. But it is an extremely well-established procedure, which has shown beyond any doubt that in appropriately selected patients who undergo coronary artery bypass surgery, it not only alleviates symptoms, but it really does improve prognosis. So chest pain can be broadly divided into two types of presentation. There's what we call stable angina. So that means that you go and make an appointment with your GP because you say to them, in the last 3 months, I've noticed that when I'm walking up a hill, or if I'm, doing some vigorous gardening or any type of work, I've noticed that I'm getting some chest pain. And you say to your GP commonly that this has been occurring for 3 or 4 weeks, and I've just noticed it, but in between, I'm absolutely fine. That suggests that the symptoms are stable. That type of patient can be started on initial treatment and then referred on to a cardiologist because the patient is relatively stable. The other side of the coin is that now and again, you'll get someone who has relatively more sudden onset severe chest pain. So one day they'll be okay, and then another day they'll wake up and they've got severe persistent chest pain that doesn't seem to go away. Now, in that circumstance, all doctors will tell you not to take any chances, that you should probably receive immediate evaluation. Now, commonly, that will be in the A&E department. And in the A&E department, there'll be doctors there who are trained to make at least an initial preliminary assessment. Now, they're not cardiologists, they're not heart specialists, but they are trained to make an initial evaluation of someone with chest pain. Now, someone with relatively sudden onset, severe and persistent chest pain, the important thing to note is that it may not be cardiac. Not all causes of sudden, severe, persistent chest pain are due to the heart, but many of the causes are. Most of the causes that present are cardiac related, but not all. But that initial evaluation should help to establish whether it's likely to be a heart-related cause. Those patients in A&E will do some initial investigations, including an ECG. They will also do a specialized blood test called troponin. Troponin is, if you like, it's a substance which is secreted from the heart when it's under stress. And if the level of that troponin is significantly elevated and your history of chest pain is consistent with it being possibly of a cardiac nature, then those doctors in A&E should formally admit you, start you on some initial medication, keep an eye on you until you get seen, hopefully on the following day, ward round by a cardiologist who can then evaluate you properly and decide whether you need further investigations as an inpatient. Finally, there is one type of chest pain whereby in that initial evaluation, when they do an ECG, if they find a certain type of abnormality on your ECG, which is known as ST segment elevation, that signifies that you are actually unfortunately having an acute heart attack at the time when you present. Now, we now have a very well-established treatment protocol for that. So if you present with sudden onset chest pain and they do an ECG and they find that it's consistent with what's known as ST segment elevation myocardial infarction, then you will be sent as an emergency to a cardiac catheter lab in order to have your arteries opened up as an emergency there and then. And in Kent, at the moment, out of hours, you will be sent to Ashford Hospital, William Harvey Hospital for that. But during working hours, when the labs are open in your local hospital, then commonly the cardiologist will be involved and can perform that procedure more locally.